All right. Hello, everybody. Thank you very much for taking the time out of your day to join us here. My name is Lance Liberti, and I'll be your presenter for today's educational health presentation on non-surgical treatments for degenerative joint disease such as osteoarthritis of the knee. Today's presentation is being sponsored by ProCare Wellness Institute in Savannah and Pooler, Georgia, which can be reached at 912-348-3818 or online at www.pcw.health. Now, before we begin today, I'd like to speak briefly about the purpose of the workshop. The first purpose is pretty straightforward, and that's to talk about non-surgical treatments that might help you find relief from your knee pain and degenerative joint disease, even if treatments such as cortisone injections, oral NSAIDs, pain medications, or even surgery has failed to provide relief. But the second reason we're here and while I'm speaking to you is hope. Because when you're diagnosed with a degenerative joint disease, it can feel a little lonely. You're being told you have something that has no known cure. Sometimes you're being told that your bone-on-bone contact and only knee replacement surgery will work for you. And I know how terrible that can feel, because like many of you on today's presentation, I was actually in your shoes just under 20 years ago. You see, I played high school football. In my sophomore year, I was blocking on a kick return, and one of the opposing players got blocked into my right knee. And not only did I have that impact, but when I went down, my foot was caught underneath them. So I had a lot of rotation and wound up tearing multiple major ligaments at the same time in my right knee. These injuries had to be surgically repaired over a course of surgeries. And while I was able to get back to walking and normal activities, I was able to pass a sports physical and step back on the football field again, or really do any heavy exercise or athletics or recreational activity from that point forward. And a few years later, those repairs actually failed, and I lost most of the function in my right knee. I thought I had sprained or strained something, and I went to get an MRI and find out what was going on. And to my surprise, I was diagnosed with early onset osteoarthritis with medial bone-on-bone contact and told that knee replacement surgery would be my only option. I was only 20 years old at the time. Now, luckily, I was working for a healthcare advertising agency at that point in time, and one of my clients, a chiropractor, his father was a pain management doctor, a doctor of osteopathy, working at a clinic up in Midtown Manhattan, injecting one of the first FDA-cleared visco supplements called Hyalgan. So he invited me to fly up and stay with him and have his father drive in from the city to inject my knee. After the first injection, I had some pain relief. By the third injection, my pain was gone. By the fifth injection, I was running and jumping and doing activities that I never thought I'd be able to do again. It was nothing short of a medical miracle, in my opinion, as a layperson. But then I got to thinking, how many other people like me are being told that knee surgery is their only option when in reality this could work for them? And we convinced the doctor to leave his position at that pain clinic and come open up a facility in southern New Jersey in partnership with us that was focused on the non-surgical treatment of osteoarthritis of the knee. And it was in that facility that we began developing the now patented advanced arthritis relief protocol, which is used in over 200 clinics nationwide in more than 40 states, including right there in Pooler, Georgia. Now, ProCare Wellness Institute is what's called a multi-specialty group. They bring in many different disciplines of providers to look at your degenerative joint disease and come up with the best solution for it. This includes medical doctors, nurse practitioners, clinical assistants, medical assistants, physical therapists, all working together to bring their expertise and experience to help resolve your knee pain without the use of drugs and surgery. They also utilize regenerative treatments there, such as platelet-rich plasma, which we'll speak about a little bit later in today's presentation. But before we get into the treatments, let's talk a little bit more about the problem, knee pain. This is something that is becoming more and more common in the United States today. According to the Journal of Bone and Joint Surgery, in 2010, there was just under 5 million knee replacements performed in our country, more women than men that received them. And today's goal is to help you learn how to save your natural knees and avoid knee replacement surgery. Now, knee replacement figures have been continuing to grow up until recently. With the onset of the COVID-19 pandemic, many medical procedures, including certain joint replacement surgeries, were deemed non-essential. So even if you're told you need a knee replacement surgery today, the wait list can be months or even years. So this is not just to avoid surgery, it's also to consider if you're really settled in on the concept of surgery, but you don't want to suffer while you're waiting for that surgical date to come around. Now, arthritis is a very common problem in the United States. The CDC estimates that 1 in 4 US adults, or about 55 million people, have been diagnosed with some form of arthritis. They expect that figure to reach nearly 80 million by 2040, at which time it will actually overtake back pain as the leading cause of pain and disability in the United States. Of all the types of arthritis, osteoarthritis is by far the most common, affecting over 32 million people at any given moment in our country, or about 1 in 10 US adults. In addition to being common, this is a very expensive condition. The National Institute of Health estimates that we spend about $250 billion annually on payments for knee pain and degenerative joint disease. This is everything from the surgeries to the over-the-counter medications like Advil and Tylenol. So it's very costly. Now, in addition to being the most common form of arthritis, what else is osteoarthritis? It's a degenerative condition of the bones and cartilage that result in pain, swelling, and loss of movement of the joints. And why the knee? Why are we talking so much about the knee? We can use these injections in the shoulder and other joints as well, but we overwhelmingly see people suffering from knee pain. And that's because it's the largest weight-bearing joint in our body and the most commonly used. We've all been walking since we were about a year old. We put a lot of miles on the knee, if you will. In addition to that, it's very susceptible to injury, not just catastrophic injuries like what I suffered playing football, or if you're in a car accident, your knees hit the steering wheel, or you fall and land on your knees, but even micro traumas. If you're walking through your house and you bump your knee on the coffee table, those little injuries over time can damage the synovial, the glands in the knee that produce the cushioning and lubricating fluid called the synovial fluid, and results in you having less of it and less viscosity of that fluid, allowing the bones to move closer together, to grind together, and to wear away the cartilage. So injury plays a big role. Mileage plays a big role. So does age. The older we are, the more likely we are to develop osteoarthritis because the more use we've put through the joint. Also weight. The more overweight or obese you are, the more likely you are to develop osteoarthritis of the knee. In fact, 2 in 3 people who are obese develop symptomatic osteoarthritis of the knee at some point in their lifetime. And it's a chicken and egg type situation because knee pain makes it more difficult to exercise and walk, which makes it easier to put on weight. The more weight you put on, the more the knee hurts. The more the knee hurts, the more difficult it is to take the weight off. So it's a very difficult situation when you suffer with knee pain. Knee pain and obesity are often hand in hand related. And last but not least, deformity, a medical condition called a varus or valgus deformity, or as you might commonly know, knock-kneed or bow-legged. The knees tend to fall out of alignment over time, especially when you're suffering from degenerative arthritis. And as this happens, it puts the entire load of that side of your body on one half of your knee. And just like if your alignment goes bad in your car and you've seen one side of the tread on the tire wear away much more quickly than the other, the cartilage in your knee responds very much the same way as the tread on the tire. It'll wear unevenly. And if you don't do something about it and correct that misalignment, it'll eventually lead to a blowout, just like on your car if you don't correct your alignment. So now I'd like to take a look at an anatomical drawing of a normal knee joint versus what some of those degenerative changes start to look like. Because before we get into looking at x-rays and before and afters and how this treatment actually works, it's important to understand what part of the knees it's working on and what we're looking at when we look at these images. So in this top image here, this triangular piece of bone here, this is your kneecap, your patella, and it glides in a little channel between what are called your femoral condyles. So the end of your thigh bone basically has these 2 balls at the end of it and a little channel in the middle that your patella will actually glide over. Think of it a lot like a sliding glass door. It'll move nice and smooth when it's on the track, but if it falls off the track, it grinds and becomes difficult to move. That grinding sensation, that clicking and popping sound that your kneecap makes called crepitus is kind of an early warning sign that you're starting to develop osteoarthritis. Now, immediately behind that kneecap, this shiny white substance here is called your articular cartilage, which is a hard cartilage similar to the consistency of your fingernail, and that protects the underlying nerve endings and blood vessels that wrap the bone. In between the 2 bones, your thigh bone and your shin bone, there's also a soft cartilage, which is highlighted in blue here, and that's called your meniscus. People with osteoarthritis often suffer from meniscal tears or loss of meniscal cartilage because that's your body's last line of defense when you have this loss of joint space and this compression. It's like the shock absorber that is there to protect the underlying bone. And then surrounding all of that is a synovial capsule full of this thick gel-like fluid called synovial fluid that cushions and lubricates the joint and keeps everything moving smoothly. because unlike that nursery rhyme we heard when we were a kid, the knee bone's connected to the shin bone, not exactly true. Our bones are not connected. They glide next to each other. They're held in place by muscles and ligaments, but the bones don't actually touch in most of the joints that move in our body, our fingers, our toes, our elbow, our shoulder, our hip, our knee. So when they come in contact, they're not designed to do so, and therefore they can break down, wear away, and fail very quickly. Now, as we suffer from osteoarthritis, we start to lose joint space, and those protective components, the cartilage, starts to wear away. Eventually, you can even wear through it, exposing the underlying bone. And the body, to try and respond to this, will actually grow more bone to try and strengthen the joint. This is called osteophyte formation or bone spurs. That's when you're growing too much bone, and the body kind of overgrows the bone at these joint spaces. But all those changes happen after the root cause of osteoarthritis, which is the breakdown of this joint fluid capsule. This capsule is full of this nice thick fluid, and it's a very special fluid. It's called non-Newtonian. What that means is it doesn't follow the laws of physics. Unlike regular water, it will not be displaced so easily. If you take a boat and you launch it into a lake, the boat displaces the water and it floats. If you were to drain that lake of water and fill it with synovial fluid or hyaluronic acid, the active ingredient in the synovial fluid, and tried to launch that boat again, it would tip over, because as you compress hyaluronic acid, it gets denser. So it's like hydraulic fluid. It's your body's natural hydraulic fluid, if you will, that cushions and lubricates the joint and keeps your bones from rubbing together, acting like a natural shock absorber. Additionally, this fluid also helps to resurface the cartilage and the bone of the joint. There are these components in it called chondrocytes. They're like your body's cleanup crew. So let's say you do suffer an injury, you get a meniscal tear. Those chondrocytes will go in and they'll eat up that torn tissue, a process called phagocytosis. And part of osteoarthritis is those chondrocytes get overstimulated and they start breaking down even healthy tissue. So that's how this whole breakdown process starts. And once you get into this cycle, it's very difficult, if not impossible, to reverse it. Now, if you've ever been walking or going up and down stairs or putting your socks and shoes on and off or getting in and out of a car, and it feels like your knee got caught on something and then released, you might actually be feeling what's called a loose body. It could be part of your bone, part of your cartilage that's actually broken off from the rest of the joint due to this bone-on-bone contact or this intermittent contact that you're suffering from. So now I'd like to show you some real x-rays of actual patients that have gone through the advanced arthritis relief protocol to show the different stages of osteoarthritis, because it's so easy when you go to a pain management facility or an orthopedic facility to be told you're bone on bone and that's that, and surgery is your only option. But the truth of the matter is there's actually 4 stages of osteoarthritis. Most people that come into our facilities are in the middle portion, the second or third phase, not in the phase that's bone on bone, even if they've been told they were bone on bone in the past. Now, that being said, before we look at those abnormal knees, I want to show you what a normal knee looks like. Not only so you'll understand what we're looking at in the next few slides, but when you go into the office for your risk-free, no-cost consultation, if you decide to proceed with the physical examination and getting an x-ray taken, you'll be able to compare what normal is to your knee and know where you are in the disease process and how to make the best decision that's right for you and your knee and your life. So starting on the left-hand side, this is a front to back view of the knee joint called the anterior to posterior view. And this faint outline that looks like a guitar pick, that's your kneecap, your patella. And you can actually see behind it that channel I was talking about that it glides in the femoral condyle. And you can also see the outline of that hard cartilage on that x-ray as well. Now, beneath that, you have your tibia, your shin bone, and this is called your tibial plateau. And these little mounds in the middle are your tibial spines. These should be smooth and round like the Appalachian Mountains, not sharp and pointy like the Rockies. If they come to a point, that means that they're being ground down. All this space that you see in between the 2 bones here, it's actually not empty space. On x-ray, the more dense something is, the more bright and white it shows up. And the less dense it is, the more gray or black it shows up. So what's inside there is actually your meniscal cartilage, your synovial fluid, all the cushioning components of the joint that are made of soft tissue, not hard tissue. So a nice thick black band is what you're looking for in a normal knee. And then last but not least, you should be able to kind of connect the dots and trace the outlines of the femur bone, the thigh bone, and the tibia, the shin bone, and they should be in proper alignment. Now here on the right-hand side, this is a lateral view. We're looking at the knee from the side. And here we're trying to determine if the kneecap, the patella, and the femur bone are coming in contact with each other, or if there's joint space between them. If they are coming in contact, that's called patellofemoral arthritis, which typically also resolves from the injection procedure that we're going to talk about here today. But nevertheless, it's something we have to look for and identify. So this is what grade 1 osteoarthritis looks like, the early stages of the disease. Here we can see a little bit of a loss of joint space and the kneecap just slightly out of alignment because that femur bone is moving inward. You can kind of see it start to bend inward like this. So the kneecap actually doesn't move very much. It's underneath a very strong ligament called the patella tendon. So think of the kneecap like north on a compass. It kind of always stays right in the center there. So based upon how much bone is on either side, you can tell if the joint space is collapsing inward or outward. In this case, it's collapsing inward. Now in grade 2, this is where people really start to get symptomatic. In grade 1, maybe your knee gets swollen or painful with certain activities, but can be managed with Advil, Tylenol, goes away if you ice it or rest it. As your joint space starts to degrade further, and now you can see these tibial spines starting to sharpen, a little bone spur beginning to form. At this stage, this is where the pain becomes really almost an all day, every day kind of thing. You're taking the maximum dose of Advil, Tylenol, Aleve. It's not really working. Maybe you're getting cortisone injections, and if you're lucky, they last for a couple of weeks of relief, if at all. This is the stage where you most commonly see people coming into our facilities. And the patients resolve very well when we catch them at this early grade. Now, moving on to grade 3, this is where the joint space loss is more advanced. You can see there's very little space left here. You can see how badly misaligned the knee is. This femur bone is kind of shifted inward. You can see the patella kind of hanging over the edge there. That osteophyte's gotten larger. It looks like half of an almond down here. And at this stage, usually people are moving to start to maybe use a cane or a walker or some type of an assisted device. There's certain activities they can't do anymore, or have to modify those activities, like maybe you have to sit down and put your socks and shoes on and off, or you have to hang on to the door to get in and out of the car. And then when you get to grade 4, this is actually bone-on-bone contact. And we don't see a lot of bone-on-bone contact. It's surprisingly rare. I was bone-on-bone. I'm going to show you an 86-year-old female patient who was bone-on-bone and had a full resolution later in the presentation, her pre and post x-rays. But maybe 5% of our patients that show up actually are bone-on-bone contact, even though probably close to half have been told they're bone-on-bone. It's a very overused term in the orthopedic facility. But even if you are bone-on-bone, that does not mean that the advanced arthritis relief protocol won't work for you. We have a unique process to hold that joint space open using an unloading knee brace to allow that medication to penetrate that compartment and cushion and lubricate the joint, along with some very simple exercises you can do in the comfort of your own home or in the office under the supervision of a physical therapist to help strengthen your ligaments, pull that joint back into proper alignment, and correct what caused your osteoarthritis in the first place. So here, I just want to point out one thing. If you look close, you can kind of see this kind of wear mark here. So that's your hyaline cartilage being worn away. You're actually seeing the underlying bone. If you've ever had a chipped tooth and you've had the nerve exposed, you know what that sharp shooting electric pain feels like. People that have worn through the cartilage on their bones will feel that type of a pain, a shooting pain down into the calf and foot or up the thigh into the buttock and low back. So if you're not having kind of an electrical shooting pain, it's unlikely that you've worn through the cartilage on your bones. It's also unlikely that you're walking around under your own power if you're grade 4. Typically, people that are grade 4 are using at least a walker, if not a wheelchair. And this is here to remind me about knee replacement surgery. This particular image is a partial knee replacement surgery where only the half of the knee that was bad was replaced. Now, this is interesting because if you happen to have a partial knee replacement surgery, they leave your knee capsule intact. They actually stitch that capsule back up, which means you can receive injections like the one we're going to be talking about here today. Also, if you do decide to undergo surgery, talk to your orthopedic surgeon about the possibility of doing a partial. Partial knee replacements only make up 5% of the knee replacements performed in the United States, not because they're ineffective, but because they're inexpensive. It only costs about $12,000 to do a partial knee replacement versus almost $42,000 for a total. Now, you might be saying, well, wouldn't they want to do the less costly one? Well, you've seen how big these hospitals and surgery centers are. They got a big budget. So I'm not trying to say that the money drives the decision-making process, but it kind of quacks like a duck and waddles. It looks like it's driving the decision-making a little bit. So talk about the partials when you go in, if you do decide to go the surgical route, and if for some reason you're not a candidate for the advanced arthritis relief protocol. That being said, very few people are not candidates for what we do, because this patented approach was designed to work when other treatments have failed and to delay or avoid knee replacement surgery. If you've tried hot and cold packs, if you've tried exercise or physical therapy, if you've tried to lose weight, if you're taking oral NSAIDs like Advil, Tylenol, or Aleve, or prescription pain medications like Tramadol or oxycodone, if you're trying cortisone injections and those are no longer providing relief, then you're in the right place. That's the average person that comes to see us for the advanced arthritis relief protocol, because our specialized unloading bracing, the injection of hyaluronic acid to rebuild up that joint space, as well as the physical therapy and/or home exercise that we prescribe to strengthen the ligaments of the knee, actually helps to correct the underlying condition, because all those other treatments that we spoke of are really just addressing the symptoms, not getting at the root cause. So let's look at those treatments like oral pain medications, opioids. Well, these medications don't fix the problem. They simply make you feel it less. And how they work is by slowing down the rate at which the nerves fire. So that nerve in your knee that's trying to send that pain signal up to the brain either sends it slowly or not at all. And this can actually be very problematic, not only because of the risk factors associated with the opioids themselves, but pain is your body's defense mechanism. It's its way of saying damage is happening, stop what you're doing, time out. If you don't feel that pain response, you can actually break down and wear away the knee even faster, because now maybe you're grinding that cartilage and you don't even notice. So that's the real problem with pain medications. So if you don't want to use the pain medications, what about the over-the-counter stuff like Advil, which is ibuprofen, Tylenol, which is acetaminophen, Aleve, which is sodium naproxen? These medications are all anti-inflammatory drugs, and they're not bad medications. They're just not meant for chronic conditions. I learned that when my daughter was under a year old. She had her first big fever. We took her into the emergency room. They woke her up and said, she's got a cold or a flu. Take her home and give her Motrin, and then 4 hours later, give her Tylenol. And I said, okay, why both? And they said, well, the active ingredient in Motrin, ibuprofen, is tough on the kidneys. The active ingredient in Tylenol, acetaminophen, is tough on the liver. So if you switch back and forth between the two, it's gentler on the organs. I said, okay, got it. I buy the medication, I go home, I peel the label to read the full instructions. I want to make sure I get this right. I've never read the full instructions before, but again, my body, right? It's crazy how we care about our kids more than we care about ourselves sometimes. So as I'm reading the instructions, it says not to be used for more than 7 consecutive days. And I said, holy cow, I was taking 6 to 8 Advil a day every day for like 2 years. Nobody ever told me you weren't supposed to use it long term. And that's where the risk factors come in with the oral NSAIDs. Over 3,500 people die from Tylenol every year in the United States. Tylenol, a drug so safe we can give it to little babies. Well, why is it killing people? Well, it actually causes liver failure. If you use enough Tylenol long enough, can eventually damage the liver. And that's why it's labeled that you're not supposed to use more than X number of pills in a 24-hour period. You're not supposed to take it for more than 7 consecutive days. Tylenol is not out there killing people because Tylenol is dangerous. It's because people are using too much of it for too long of a period of time. So that's where the risk factors with the NSAIDs come in. It's not meant for people with chronic conditions like you or I. It's meant for people with acute conditions, like if you fall and get a bruise or a swollen joint, or if you have a fever or something that's going to pass. That's what these medications are really meant for. So if you don't want to use these prescription pain medications or over-the-counter NSAIDs, looks like surgery is your only option, right? This is wrong. What else is wrong is that surgery itself is not a guarantee. And it's even the orthopedic surgical community themselves that's calling this into question. Renowned orthopedic surgeon, Dr. Kenneth Mathis, chairman of the Methodist Center of Orthopedic Surgery in Houston, was quoted as saying, over the next decade, we'll see a more than 600% increase in revision knee replacement surgeries. What's that? What's a revision knee replacement surgery? Well, that's where the first set of hardware that they put inside your body fails, becomes infected or loose or breaks. And there's over 60,000 revision knee replacement surgeries performed in the United States every year. It's not uncommon. What else is not uncommon is poor results. According to certain research studies, up to a third of patients are dissatisfied with their knee replacement surgery after only a year. And last but definitely not least, the risk of death with knee replacement surgery is a little higher than you might realize. In fact, 1 in 200 people that undergo knee replacement surgery pass away within 90 days as a result of complications of the surgical procedure itself, not some other coincidental thing that causes their early demise, like getting hit by a bus or catching the flu. And what's worse is if you have bilateral osteoarthritis and you get both knees replaced, those are two separate surgeries. Now there's a 1% chance you might not make it. So those are not great odds. Additionally, once you have knee replacement surgery, you're kind of stuck in the surgical path because in a total knee replacement pictured here on the right-hand side, the joint capsule is actually removed from your body, that fluid-filled cushioning layer. So now you just have metal and plastic kind of grinding together, and that'll slowly wear away over time. The average knee replacement surgery only lasts for 8 to 12 years. So if you're planning on living for longer than 8 to 12 years, it's a good idea to delay or avoid this knee replacement surgery as much as possible. And what about anesthesia, the dangers associated with anesthesia? Well, we all know that risk of potentially not waking up for anesthesia, which is very rare, but a much more common condition is called postoperative cognitive dysfunction, or POCD. This happens to about 12% of people over 60 years old that have undergone surgery with some type of anesthetic to put them under. And what this is your body doesn't metabolize all that anesthetic quickly enough. The most common anesthetic used in surgery is propofol. It's the same medication that Michael Jackson passed away from. The active ingredient in it is similar to fentanyl, the drugs that we see being smuggled over the border and killing all these young people. It's a very powerful medication. A little goes a long way. But the problem is different people metabolize it at a different rate. Some people have a fast metabolism. I'm sure you've known somebody that no matter what they eat, they don't put on weight. Conversely, I'm sure you know somebody that's constantly dieting and exercising and eating nothing but salads and they can't take weight off. Maybe that person is saddled with a slower metabolism. Well, if you have a slower metabolism, it's going to take longer for your body to wear off this anesthesia. When I undergo surgery, like I had a sinus surgery 7 or 8 years ago, for 2 to 3 days afterwards, I kind of had muscle convulsions and these involuntary muscle spasms because my body hadn't metabolized all that anesthesia yet. For some people, it can take weeks or even months, and that can result in loss of memory, confusion, and even increased risk of cerebrovascular events like heart attack or stroke. But we're not here to scare you. We're here to help you avoid these drugs, surgeries, and complications. There's an easier, safer, less costly way covered by most insurances, including Medicare, that actually outperforms the results associated with surgery without the risks. Now, that's because everything we spoke about up until now addresses the symptoms of the disease, not the cause. Osteoarthritis actually starts out as a drying problem. We have less synovial fluid than we used to, and it's less thick than it used to be, allowing the bones to move together and that friction to start destroying cartilage and other structures. So there's a little science experiment you can do in the comfort of your own home to understand how this works. Take a regular commercial sponge, get it soaking wet. Try and rip it in half. No matter how hard you try, you're going to struggle. Crumble it up into a little ball. It's going to spring back to its original shape very quickly. Now let it sit for a day or two to where it's still moist but no longer soaking wet. Now try and rip it. You'll probably be able to tear it, crumble it up into a ball. It's not going to spring back to its original shape as quickly or at all. Let it sit for another day or two until it's bone dry. Now you don't even have to try to tear it. Take that sponge, put it in your hand, make a fist, and it's going to crumble like dust. Why is that? Why is that sponge so much weaker than it was just a few days ago? It's the same sponge at a molecular level. Nothing's changed. All it changed was the hydration. And our bodies are 85% water. Many things in nature get their strength from hydration, just like this sponge. Our cartilage is not much different than that. When it's properly lubricated, the cartilage is very strong. And the ligaments are very strong. That's why you can see people playing professional football or MMA fighting or rock climbing or skydiving, and the body can withstand these things, right? But if you have osteoarthritis, you can barely take a few steps without being in excruciating pain. Well, the difference is that properly hydrated and properly cushioned joint. So your synovial fluid not only changes in volume, but also in viscosity. it becomes less dense. Think of it like joint oil slowly turning into joint water and no longer being able to withstand that friction or any type of impact. So wouldn't it make sense to fill the joint capsule back up with nice thick fluid again? This is not a trick question. This is actually what we're proposing. It's called joint lubrication therapy, an injection of a naturally occurring substance called hyaluronic acid, which is already in all the joints in your body, but you simply don't have as much of it as you used to, which is leading to these problems in your knee or shoulder, whatever joint happens to be ailing you here today. And these injections are a lot different than other injections you've had in the past, like cortisone injections. You see, cortisone is a powerful anti-inflammatory. If you have a sinus infection, like I do right now, I was prescribed prednisone. So I have to take, I think, 10 milligrams of prednisone every day. And after you're on this prednisone for 2 or 3 days, it starts to dry things up. All of a sudden, your nose dries up, your cough dries up. That's how this medication works. So if we have a drying problem, wouldn't injecting a corticosteroid into it make it worse? Again, not a trick question. It actually does. And major institutions like the Mayo Clinic are no longer performing these procedures on people with osteoarthritis of the knee because the risks outweigh the benefits. And it's not just the drying out of the joint that can make it worse. These injections are also very acidic. If you've ever had a cortisone injection before, it probably stung or burned. That was because of the acidity of it. And that'll actually break down tissue around the injection site, including bone. You can lose up to 8% of the mass of the bone near the injection site in only 120 days. Also, these medications are made of a complex sugar. The full name of cortisone is glucocorticosteroid, glucose from sugar. Cortisone actually comes from a sweet potato that grows in the Amazon rainforest. So when your body breaks down cortisone, it increases your blood sugar levels. That's why if you've ever been on steroids, maybe you feel hyper, you have difficulty sleeping. It's because you're very literally suffering from a sugar high. So cortisone can actually make matters worse, not better. A little food for thought. Also, the FDA does not recommend more than 3 injections of cortisone in any body site or region in a lifetime. How many of you had more than 3 injections of cortisone? I know I did in my right knee. No one ever told me this. So better idea, change the joint oil. Medical procedure called viscosupplementation using FDA-cleared medications like Hyalgin, Genviscate 50, Trivisc, and others. We can replenish the hyaluronic acid that you're currently deficient in to build that joint space back up, to stop the friction and destruction of cartilage, and to give your body a chance to recover and regrow that cartilage and or bone that may have been lost as a result of your osteoarthritis. So now I'd like to play just a brief little 2-minute video that shows the procedure being performed so you can better understand what we're talking about here today.
Osteoarthritis, also known as degenerative joint disease, is the most common type of arthritis. With osteoarthritis, the surface layer of cartilage breaks down and wears away. This allows the bones under the cartilage to rub together, resulting in pain, swelling, and loss of motion of the joint. Although in some people it progresses quickly, in most individuals, joint damage develops gradually over years. Viscosupplementation therapy is a non-surgical outpatient procedure by which a pain relief medication called hyaluronic acid is injected into the knee joint. This medication mimics the body's synovial fluid of the knee that lubricates the cartilage. Hyaluronic acid will help the knee to move smoothly, reducing or relieving the pain of osteoarthritis. In preparation for the injection, the physician sterilizes the knee and administers a local anesthetic. The physician positions an imaging device called a fluoroscope over the knee. The fluoroscope will display a moving X-ray of the inside of the knee that will ensure the hyaluronic acid reaches the joint space. The physician carefully guides a needle into the joint space. The physician confirms the placement into the knee joint with an injection of contrast dye. The contrast dye is clearly visible on the fluoroscope image. If the dye pools in the soft tissue at the front of the knee, the physician will adjust the depth and angle of needle placement until the joint capsule of the knee is reached. When the contrast dye flows throughout the joint capsule, the physician knows they are ready to inject the hyaluronic acid. While leaving the needle in position, the physician removes the contrast dye syringe and replaces it with a syringe filled with hyaluronic acid. The physician injects the hyaluronic acid into the joint space within the knee. The hyaluronic acid will bond with the synovial fluid inside the joint, cushioning and lubricating the joint. When the injection is complete, the physician removes the needle and bandages the knee. Ice is then applied to reduce swelling. Hyaluronic acid is administered in a series of 5 injections 1 week apart. Pain relief can be immediate and has been shown to last for 6 months or longer. In addition to the hyaluronic acid injections, knee bracing and physical therapy are utilized to enhance the effects of the medication.
So hopefully that video gave you a better understanding of what we do. Now, before we proceed, I always get 2 questions after that video. The first is, it says it only lasts for 6 months. Well, I made that video about 12 or 13 years ago. And at that point in time, there was no longitudinal clinical research that followed up with the patients for more than 6 months. But since then, there's been very large studies, including this study right here, the Osiris study, that followed up with patients for 3 years. And at that 3-year follow-up in thousands of patients, over 82% still had a positive improvement versus prior to the injections. Just to put that in perspective, that beats the surgical outcomes by almost 30%. So not only is this procedure faster, safer, less costly, almost completely painless, but it also works better than surgery in some clinical research that compare the outcomes of the two. Now, the other question I always get is, does the procedure hurt? And I can tell you, speaking from experience, no, it does not. And that's because we use 2 different types of anesthetic in the facilities. One is a freezing spray called ethyl chloride, and it actually freezes the skin before we insert the needle, so you don't feel that pinch of the needle. And then we'll typically use lidocaine 2% or another anesthetic to numb the knee. So on the approach to injecting that contrast dye, everything's getting nice and numb. So most people say that this hurts a lot less than even a flu shot or a vaccination. So very, very painless procedure, even for people that are afraid of needles. It's also a very fast procedure. The whole procedure end to end is about 90 seconds or less. So you're in and out very quickly. This is not a big drawn out process. Also, there's no known side effects or drug interactions to these medications. So it's not going to interfere with any medication you're currently on. It's not going to make your problem worse. Your worst case scenario is you don't get better. So it's a very, very low risk, almost risk-free procedure. And the idea behind hyaluronic acid injections is to cushion your joint, lubricate your joint, but most importantly, to bind with the fluid-producing cells called the synovicytes, to begin stimulating them to create more hyaluronic acid on their own again. So unlike other treatments you might have tried in the past, we're not trying to cover up the symptoms. We're actually trying to correct the root cause, which is that synovicyte dysfunction. It's the other reason why we recommend exercise or physical therapy, because there's only 2 things that are known to stimulate these synovicytes. One is the presence of hyaluronic acid, and the other is weight-bearing activity. So if we can reduce the pain so you can move a little bit more, that movement's actually going to help to stimulate these glands even further and correct or even reverse your osteoarthritis. More good news, viscosupplementation is actually an all-natural substance. That's why it's called viscosupplementation. Hyaluronic acid already exists in all the moving joints in our body. You simply don't have enough of it. The only downside is this is not something you can buy from the grocery store or the health food store. It's not something you can rub on your skin or take in pill form. Because it's very dense and gel-like, it has to be placed directly inside your knee capsule in order to work. And that's actually one of the reasons that these injections may not have worked for you in the past if you've had them before. And I'd like to talk about some of the catches, if you will, if this sounds like it's too good to be true. So if you've had these injections in the past and they didn't work, part of it is how it's injected. If you didn't see inside the joint capsule, if there wasn't contrast dye used to confirm needle placement, there's a good chance the medication didn't reach where it needed to go. And unlike other injections, this medication is so dense it won't cross tissue membranes. In fact, if you've ever heard of facial fillers like Juvederm, Restylane, or Voluma that people use to, raise their cheeks or fill in their smile lines, they're made of hyaluronic acid, the same ingredient that's in this, because when you inject it in the skin, it's too thick for your body to get it out of there. And it takes months and months and even years for the body to break it down into a smaller size and move it away. So medicine or physicians have discovered this, and that's why they use it as a filler. Well, it's naturally occurring in our joints to work very much the same way, to keep that density to act as a cushion. So if it doesn't get in the capsule, there's no chance of it working. It also matters what was injected, what medication was used, and how often was it injected. There are injections out there like Synvisc 1 or Monovisc or Gel 1, single shots, where they do a mega dose, 100 milligrams or more of hyaluronic acid all at once. Well, this has been shown to be less effective than a smaller dose over time. We typically use medications like Hyalgin or Genviscate 50, which are 20 to 25 milligrams per injection 1 week apart for 5 weeks. Why? Because it's stimulating those synovicytes every time we inject it. It's helping to retrain them to work normally. I mean, of course, if we could do just one quick shot and fix your problem, we would. But the truth is, over time, people that have those single injections get much worse results because it goes back to the problem they were suffering from as soon as that medication is worn away. And your body can metabolize this medication very, very quickly in as little as a few days. So it's very, very much a temporary fix. What's the long-term fix is that we're stimulating those glands to work normally. So every time we inject this, you're getting a few days of artificial cushion from the injection, but it's also building up your body, creating that cushioning fluid on its own. So hopefully by the end of this, you won't have to come back in and you'll have a normal, healthy knee for years or even the rest of your life. Also, when you had these injections done in the past, was bracing provided, especially if you're bone on bone? How's that medication going to get in that compartment if there's no room for it to get in? So we use a very special patented unloading knee brace to open that space up, allow medication to get in and do its job. Also, were you given physical therapy or a home exercise protocol to perform? And this is important because in all those x-rays we looked at back at the beginning, the bones were out of alignment, right? So what holds the bones in alignment is the ligaments that run around the outside of them and the muscles. So we're not trying to, turn you into a bodybuilder here, but we are trying to strengthen certain ligaments to pull the bone back into alignment so that you no longer have that uneven load and your body can repair and recover and not wind up in a situation where it wears its cartilage away again. Also, there are certain medications that, let's just say I'm not a big fan of. One of them is a medication called Synvisc. This is the only FDA cleared medication in this category that has a different active ingredient. Every other medication is hyaluronic acid. This one is a synthetically manufactured chemical component called hyaline that looks like hyaluronic acid and acts like hyaluronic acid, but it isn't actually hyaluronic acid. And people have been known to have a lot of side effects from this medication and also worse results. In fact, according to the American College of Rheumatology, they said in a research study, in view of the likely lack of a superior effectiveness of hyaline over hyaluronic acid and the increased risk of local adverse events associated with hyaline, we discourage the use of intra-articular hyaline in patients with osteoarthritis of the knee in clinical research or in trial. So if you've had Synvisc before and that didn't work for you, don't worry. We use different medications inside of our facility, and many people that haven't responded to Synvisc actually get great results with us and with our advanced arthritis relief protocol. So now let's look a little deeper into each one of those components. According to the American Journal of Sports Medicine, 21% of injections into the knee fail to reach the joint capsule. So 21% of the injections out there being done, they're not going to work because if that medication's not inside the capsule, there's no chance of it working. So we use these video x-ray machines called fluoroscopes, like what are pictured here on the right-hand side of the screen, to see inside the knee in real time and inject that contrast dye. That way we know we're where we need to go. This is what an actual image looks like of a real knee under injection. This long line you see here, that's actually the needle. We can see it on approach. And then this kind of black dye that looks like the Batman logo with a tail. That's the contrast dye. So when it spreads out behind the femur bone and up behind the patella inside the capsule, we know we are where we need to be to inject the medication. So that's how we 100% guarantee that the medication gets where it needs to go, which is the biggest part of the battle, getting it where it needs to go. Once it's there, it tends to work quite well. And when combined with the unloading knee bracing and the physical therapy in randomized published clinical research from a multi-center study, we had nearly a 93% success rate where people had a 50% or greater reduction of pain, improvement of function. In fact, in this study of 384 patients, only one person had no improvement. So very effective. That's why our patented three-step approach works. The hyaluronic acid injections build up your joint space and cushion and lubricate the joint. The knee brace holds that joint space open temporarily while the medication is doing its job, a lot like a scaffolding. And then the home rehab devices we utilize help you strengthen and stretch your ligaments so that it pulls your joint back into alignment and corrects the underlying condition. The best part is this program's covered by most insurances, including Medicare. So this is not something you're gonna have to pay out of pocket for if you have Medicare in a secondary, if you have TRICARE for Life, TRICARE Prime. So many insurance plans actually cover this in full. And even if you don't have full coverage, the average out-of-pocket cost is only a couple $100s, not thousands and thousands of dollars like the coinsurance for surgery or other interventions. Now, I just want to show you briefly how the knee brace works. This is a bone-on-bone contact knee medially on the inside of the knee on the left-hand side. And here on the right-hand side is the same knee just a few minutes later after the application of the brace. So you can see where that joint space has been open. Now it's going to allow that medication to penetrate that compartment and cushion and lubricate the joint. This is a lot like if you've ever seen a historical building and it's starting to become weak and tilt and the foundation is wearing away. The engineers will put up that steel scaffolding around the building to hold it in place while they pour a new foundation. That's what the knee brace is. It's something you're going to wear temporarily for weeks or months, depending on how bad your condition is, to hold that space open while we're rebuilding the foundation. And even if you're lateral bone-on-bone contact, this knee brace can be applied as a negative pressure to open that joint space as well. Now, this is that 86-year-old African-American female patient I promised to show you the x-ray of. When we first met her in January 2011, which is where this x-ray on the left-hand side was taken, she was in a wheelchair, couldn't stand, couldn't walk, and she was in a nursing home. She was very overweight, suffering from diabetes, heart disease, COPD. Excuse me. She was not in good shape. Here is the exact same knee on the right-hand side 26 months later. You can see there's joint space where previously there was none. But if you remember on x-ray, the more white something is, the more dense it is. Look at how much more dense her bone and her muscles are. That's because she went from being in a wheelchair to a walker to a cane to, by the time we took this x-ray, walking under her own power. So that was absolutely life-changing for her. She got out of the nursing home, got into an independent living facility. She lost over 60 pounds. Her heart disease, diabetes, and COPD improved. She got off of a bunch of medications. This is not just about knee pain. Oftentimes, knee pain, which keeps you from moving, can cause metabolic diseases and other conditions that become difficult to manage. Getting rid of that pain can not just be the first step to literally moving again, but also to getting healthy overall. So now I'd like to encourage you all again to take advantage of the risk-free, no-cost consultation. If you'd like to do so, just type in yes into the chat box, along with the best phone number to reach you at, and someone from our scheduling department will get you on the books for the next available consultation at the facility in Cooler, Georgia. I'd also like you to start thinking about what you want out of this procedure. Obviously, everybody wants to reduce their pain. That's a given. But what type of activities do you want to return to? And the reason we ask this is, let's say you want to go back to golf, right? Golf is a sport that requires rotation. We're going to give certain exercises that are going to strengthen the lateral ligaments of the knee so that when you go back on the golf course, you're going to have that stability to do that activity without causing damage to your joint and to your cartilage that you've regenerated. So this is not just for conversational purposes. What you want to do actually has an impact on the type of therapies we're going to provide. Now, the last thing I'll discuss with you before I start taking your questions is regenerative medicine. Now, while I'm doing this, if you have any questions, you can type them into the Q&A box, or if you'd like to ask a question over the microphone and speakers, you can do so by clicking to raise your hand. If you scroll your mouse over the control panel, there's a little hand icon. If you click on that to raise your hand, I'll be able to unmute you so you can ask your question. So while you're getting your questions ready, let me talk briefly about regenerative medicine. Platelet-rich plasma therapy is something we do when a patient is suffering from a meniscal tear, or the hyaluronic acid injections only do so much to help, and there's more room for improvement. This treatment works by concentrating a small amount of plasma from your whole blood, 10 milliliters of blood, the same amount you give annually when you go to your primary care doctor for your lab tests. And in that blood, we're concentrating the growth factors and the platelets that are responsible for healing. If you've ever cut yourself, after the red blood stops flowing, that clear or yellowish fluid you see that forms a scab, that's your plasma. And the platelets inside of that plasma are what's forming the scab. When they do that, they release these proteins that attract other cells to the area called fibroblasts. And fibroblasts create collagen, elastin, and fibronectin, the building blocks of skin, muscle, ligaments, and soft tissue. So in a few days, when that scab falls off and you have fresh skin there, that's the process that took place. Now, the problem is with your knee joint, your shoulder joint, your hip joint, your elbow, any of these large fluid-filled capsules, they don't have a great blood supply inside of them. Plenty of blood supply outside of them, very little blood supply inside of them. So they heal very slowly. So that's why we're borrowing these healing components from your peripheral blood and then putting them inside the joint space to help stimulate it to grow more quickly on its own than it would without this procedure. Now, this x-ray is a real patient that went through platelet-rich plasma injection. Let me just try and zoom in a little bit. There we go. So this is from one of our clients outside Pittsburgh, Pennsylvania. This was an 88-year-old male patient, and he got a little bit of improvement from the hyaluronic acid injections. You can see kind of a hairline of space there on the left-hand side, but he didn't have a typical great improvement that we get with most patients. That was because he had worn away so much of his cartilage. So we did 3 injections of platelet-rich plasma 1 month apart, and that x-ray on the right is after that procedure was performed. So you can see that increase in joint space that actually came from the cartilage regrowing and holding that joint space open. So that's how we use PRP. And PRP is starting to be covered by certain insurances like TRICARE. So if you're military, retired military, or dependent on a military member, your insurance is actually going to cover this. If you have a work comp claim, your insurance is going to cover this. If you've been in a car accident, your automotive insurance is going to cover this. However, Medicare and most commercial insurances don't yet cover platelet-rich plasma. That being said, we created our own FDA-cleared line of processing kits to reduce the cost, increase the speed and effectiveness of this procedure. So unlike when it first came to the United States in 1995, Tiger Woods was one of the first people to get PRP. He paid $500,000 to a Canadian physician to come down and do that procedure. Well, nowadays, this is not a multi-$1,000 procedure, reserved for celebrities and athletes and the wealthy. It's a couple $100 procedure. So platelet-rich plasma has become much, much more inexpensive as the technology to create it has become faster and more effective. So now I'd like to take any questions that you all might have. So if you're ready to book your consultation, please type in yes, your name, and the best phone number to reach you at into the chat box. And a new patient coordinator will contact you to schedule the next available review with the medical team there. And if you'd like to reach out to the facility directly, you can reach ProCare Wellness Institute at 912-348-3818 or online at www.pcw.health. That being said, let's see what kind of questions we have here today. So Harriet asks, have you ever heard of the PRP injection? What is your opinion? You must have typed that before we got to the last few slides, Harriet. So platelet-rich plasma is a great procedure if you have soft tissue damage, because it's concentrating what heals soft tissue. So if you have a meniscal tear, if you have a ligament injury, any type of soft tissue injury is typically going to respond well to a platelet-rich plasma injection. And I think I saw somebody raise their hand. So we have Noel, you raised your hand. So I've clicked to allow you to talk. Now you just have to unmute yourself. So take your mouse and scroll over the microphone. There you go. What's your question, Noel?
I wanted to know if there was any side effects from the dye.
Great question. So the dye is made of iodine. So anybody who is allergic to shellfish or has a known iodine allergy could be sensitive to it. However, people that have iodine allergies to imaging, let's say you go get an MRI with contrast or a CT with contrast, they're typically using 200 to 300 milliliters of contrast intravenously. When we do this injection into your knee, we're using 2 milliliters or less than 1% of what's typically used. So if somebody's not sure if they have an iodine allergy or not, maybe they're allergic to shellfish and they're not quite sure, we'll do a little small injection under the skin and we'll set a timer for 15 minutes, see how that responds. If it gets red and swollen and itchy, we'll put some Benadryl on it and we'll skip the injection or pre-dose you with Benadryl before using the contrast dye. Now, even if we can't use the contrast dye, we can still see the needle on the image. So if we get close to that femur bone, we know we're probably inside the capsule, but without hitting the bone and causing pain or discomfort. So if we have to skip the contrast dye, we can do so. We also have non-iodinated alternatives, a medication called Prohance that we can also use in people with iodine allergies. Next question is from Mar. What is your question? And scroll your mouse over that little microphone icon and click it. There you go. What's your question?
Is that me?
Yes. What's your question?
Okay, last year I got the gel shots. They really didn't do anything for me. I have to walk with a walker. My thing is, I do not want to walk with a walker. I can take a stick, but I do not want to walk with the walker. But when I got the gel shots, they put the stuff on both sides of my knee. But I was bone on bone, they say, and the gel did not go no further, making the middle of my knee did not get anything. I was never able to walk any. So that's what I want. I can walk, but I have to walk with a walker. I want to
Now,
know
I'm
if
sorry,
you
when
all
you
can
had
help
these
me.
injections last year, did they happen to use an unloading knee brace on you, especially since you're bone on bone?
Well, they gave me a knee brace, but they said I didn't have to use it. The only time I needed to use it, if I was like doing a lot of walking or working or anything like that, I could put it on. But ordinarily, I didn't have to use the new brace because I was immobile, so I did not use it.
So there's different types of knee braces out there. There's some that are kind of like straps that you pull tight. Some are soft. Some have a hinge on both sides of your knee to restrict range of
That's what
motion.
I had. Mhm.
There we go. So the way that one works, that's commonly used when people have sports injuries, and it's designed to keep you from moving your knee too much and to stabilize it. When you have osteoarthritis, typically you can't move your knee much anyway. So we have a single hinge brace that is a little different than that. It's actually designed to unload the part of your knee that's bone on bone contact, because you're very right. If you had those injections without that space being opened up, it's not going to get into that compartment and do its job. So we use this unloading knee brace to increase that joint space so we can get the medication where it needs to go. Now we can do something special for you since you had this procedure in the past and it didn't work. Because we have x-ray inside of our facility, we can actually put the knee brace on you, provide the corrective pressure to open that joint space, and then take another x-ray of your knee. So you can see if we were actually able to open that joint space with the brace or not. If we opened the joint space, now you know that the medication can get into that compartment and do its job. So we can actually test fit you for the brace, see how your body responds to it. And if we can get that space open, now we know we can slowly increase that space by getting the hyaluronic acid in there and slowly hydraulically unloading that joint and opening it up. So that's what I would recommend in your particular instance. Go in for the risk-free evaluation, get test fit for the knee brace, see if it opens your joint space. And if it does, there's a good chance that we will be able to get positive results for you. Does that sound fair enough?
Yes, it sounds a little bit better. I would like
Excellent.
to try.
Well, I look forward to you getting that evaluation. And speaking from experience, we've helped many thousands of patients that were bone on bone find relief. In fact, in the 14 years we've been doing this nationwide, we've helped over 600,000 people delay or avoid knee replacement surgery throughout our network. So you're not alone. And while I'm sorry that your previous injections didn't work, I'm confident our approach might work where that one did not. So please take advantage of that risk-free consultation and let's see if we can get you out of that walker.
Thank you.
You're welcome. Thank you for your question. All right, next question is from James. James is using an older version of Zoom. Oh, James, I'm sorry, sir. Your version of Zoom apparently won't let me unmute you. So if you can't get to the question here today, try and type it into the Q&A box. And if you can't do that, please write it down and bring it with you to your risk-free, no-cost consultation. I apologize. All right, next question is Demetrius.
Hello.
Hello there. What's your question?
Okay, I want to ask you a question. I recently started going to Chatham Orthopedic. I haven't had any shots or anything yet. I did an MRI, and on my right side in my knee, it gives me so much pain until I can barely walk on it. Do you all think that y'all could do anything with it? I don't take any
Possibly.
kind of pills or anything, because I told him when I started with him about 2 weeks ago, I didn't want any Percocets or nothing like that, because in the past it has not did any good, and I needed to get to the bottom of the solution. And I was seeing another doctor, but she retired. She gave me a shot in my knee back in May,
A cortisone injection?
a cortisone injection. I was supposed to get another one in August, but they called me in July and said she retired in June. So that's how I got referred over to Dr. Spellman. The only thing I did with him so far is just took an MRI, and I got the disc to take to him. But my knee, he gave me some patches to use. Those
Oh,
patches haven't did
lidocaine
anything.
patches.
Yeah,
Yep, I'm familiar with those.
the
So it sounds
patches ain't
like
did nothing.
people have only given you kind of like temporary treatments and things for the
Yeah,
pain, not something to correct the underlying condition. So it
and
does
it's
sound
not
like you're likely to be a good candidate for the advanced arthritis relief protocol, but that's what the risk-free no-cost consultation is for. Bring that
okay.
MRI disc with you, get worked up
Okay.
by the team. The first thing we do during that consultation process is make sure if somebody's not a good candidate, we're
Okay.
very clear about that. We only accept people into the program who we're likely to help. So if you're in a condition that is unlikely to respond to this, we'll let you know so we don't waste your time or your money if you have any copay or coinsurance due.
And I have
That
lost the weight because I had a gastric sleeve last year in August. So I was at 4'8" at that time, and I knew that had a lot to do with my knees hurting too. So I've lost 124 pounds.
wow,
So I'm
congratulations.
down to 280 now. So,
That's amazing. Keep up the good work.
but I got like 80 something more pounds to reach my goal weight. So the pain is only giving me problems on my right side. It's like sciatica and then the arthritis pain in my knee because it hurts so bad until if I sit down and get up, it just pains. And then I have to, when I get up, I have to stand for a minute but I do a lot of walking on it so I won't get really stiff.
So if
But
you have that
nothing
shooting pain on that right-hand side of your body, that's
Mhm.
likely either a nerve being impinged from the joint space collapsing or the
Mhm.
nerves that wrap the outside of the bone being exposed. That's really consistent with advanced osteoarthritis. We see that a lot in the patients that come into our facilities around the country. That's not a bad thing. We get good results with people that present very similarly. So hopefully this will work for you. Please
When
take
I went
advantage
to the
of the consultation.
hospital, they did x-rays and they told me that I had sciatica and arthritis in the hip. And it travels down my right leg and my knee and down my leg, and it gives me a time.
Well, bring those x-rays with you if you can. If not, we do have x-ray in the facility, but that's the purpose of this consultation, and it does sound like you're
Okay.
likely to be a good candidate. Thank you very
Do
much
you
for your
now?
question.
I have Medicaid and Medicare.
Excellent. That means you have full coverage. So
Mhm.
Medicare is going to pick up the majority of the procedure. Medicaid is going to cover what your Medicare doesn't. So you're not going to
Yes.
have any out-of-pocket costs. It's not going to cost you anything for the injections, the bracing, the home rehab device, or physical therapy. And since you're trying to lose weight post-gastric bypass surgery there, maybe take advantage of the physical therapy, work with our physical therapist to put together an exercise plan for you that
Mhm.
not only would work on your knee, but also help you to further your weight loss goals and get to that last 80 pounds you're looking to take off.
Okay. So do I wait for them to call me to set up the appointment, or?
If you put your phone number into the chat box, we will be reaching out to you. And if you'd like to call the office directly, you can do so at area code 912-348-3818.
Okay, I put it in the chat box, my name and number.
Excellent. We'll give you a call. Thank you so much.
Okay, thank you.
You're welcome. All right, let me see if I can get to some of these written questions real quick. James asks, do you perform stem cell injections? Great question, James. So I guess the short answer to that is yes, but stem cells are a unique thing because if you're using a stem cell therapy, stem cells are alive. And before they turn into adult cells, they go through a process called homing and diversification. Stem cells are attracted to inflammation and apoptosis, the clinical term for cell death. Now, let's say you're bone-on-bone contact, for example. The cells that are dying at the fastest rate in your knee are going to be bone cells, osteoclasts. So if you inject stem cells into an osteoarthritic knee that's bone-on-bone, they might actually turn into bone tissue and create more bone spurs than you already have, which can actually make your condition worse. We oftentimes see patients that have paid tens of thousands of dollars to have stem cell procedures performed elsewhere, and they come to us in worse pain than they were before because of that very process. So can we use stem cell injections in our facility? If we have to, yes, but they have to be done at the right time and under the right circumstances. If you're bone on bone, first we're going to work to increase that joint space. because now those stem cells are more likely to diversify into fibroblasts and to start building new cartilage, which is what we want them to do. Also, the other conditions you're suffering from matter. We had an elderly male patient once at our facility in New Jersey. We did the stem cell injections into his knees, and he didn't have any improvement in his knees, but he did have a ton of improvement in his lungs. He was suffering from COPD. He was actually on an oxygen tank and had difficulty breathing, difficulty walking. You know, he came back a month later, no oxygen tank, breathing great, but his knees were still just as painful as they used to be. And that's because the inflammation in his lungs was worse than the inflammation in his knees. So the stem cells traveled to the lungs and healed that issue instead of the problem in the knees. So it's a very complex evaluation that's performed when we're looking at using mesenchymal stem cells or other human tissue products for cellular regeneration. So can we do stem cell injections? Yes. But we're going to do a really thorough and honest workup before recommending that. We're also going to try all the things that are covered by your insurance first. Everything we discussed here today is covered by insurance. Stem cells are thousands of dollars out of pocket. So we're going to start with the hyaluronic acid protocol, and then maybe move into the platelet-rich plasma, which is only a few $100s. And only if that doesn't work, look at stem cells as an option. So I hope that answers your question, James. And Noel, I hope that helps to explain the difference between the platelet-rich plasma and the stem cell therapy. One is triggering your body's natural healing process, platelet-rich plasma. The other is actually putting undiversified cells into your body, hoping that your body takes those building blocks and uses them to rebuild tissue. Now, I've seen and used stem cell therapy many times over the years. It's quite effective when done properly. But again, you have to be very careful with it because those are live cells and you have to ensure they're putting them into an environment where they're going to work properly. You also have to make sure that the patient's a good candidate for it. And, you know, last but not least, there's the financial consideration. Stem cells are not covered by insurance at this point in time. All right, so I think I got to almost all the questions, if not all the questions. We are a little over on time right now. So if for any reason I did not get to your question, please write it down and bring it with you to your risk-free no-cost consultation. And you can schedule that by reaching out to ProCare Wellness Institute in Pooler, Georgia at area code 912-348-3818, or you can find them online at www.pcw.health, not .com, pcw.health. Also, if you'd like to take advantage of the risk-free no-cost consultation, just type in yes, your name and the best phone number to reach you at into the chat box, and our new patient coordinator will reach out to you to schedule the next available appointment. I'd like to thank you all for your time here on today's presentation. I hope that you learned something new about osteoarthritis and more importantly about a potential solution for it in yourself. And I'd also like to encourage you, because this presentation was recorded, if you have a friend, a family member, a coworker, anybody that you know who's also suffering from osteoarthritis of the knee or shoulder or degenerative joint disease, please share this presentation with them. If you'd like a copy of today's presentation, just type your email address into the chat box and we can get a copy to you in about a day. It has to render and save. And then you can share that with your loved one. Also, if you have a spouse or anyone else that's part of the decision-making process for your condition, this can be shared with them as well. Also, again, if you have a spouse or a caregiver, please bring them with you to the risk-free no-cost consultation so that they can hear from the clinical team on your condition, whether or not you might be a good candidate, how frequently you're going to have to come into the office, especially if that person is driving you. So please, we invite anyone who's interested in being part of your decision-making process and supporting your recovery to come in to that consultation with you. Thanks again for your time today. I wish you the best of luck on your consultations. I hope that is the first step to you finding relief, as it was for me and so many thousands of other patients throughout the country. I wish you the best of luck on your recovery and hope to see you all out and about walking under your own power without pain again real soon. Thanks again and best of luck.